Thanks a lot for joining in for yet another panel discussion on the first day of Radiology and Imaging Summit. We are here to discuss a very important, uh, panel discussion here. The topic would be diagnostic imaging solutions and its impact on COVID-19. So, I would quickly like to introduce the panel members here. Dr. Deepak Patkar, President IRIA 2020, Director Medical Services, Head Department of Imaging, Nanavati Super Speciality Hospital. Welcome, sir. Dr. Sikandar Sheikh, Consultant, PETCT Radiology, Yashoda Hospital, Hyderabad, Assistant Professor Radiology, Shadan Medical College, Adjunct Assistant Professor, Department of Biomedical Engineering, IIT Hyderabad. Dr. Jijo John, who's also joined us, Consultant, Interventional Radiology, Amala Institute of Medical Science. Welcome, sir. Dr. Geetanjali Nanda, Consultant Radiologist, Mahajan Imaging, and Dr. Midusha Verma, Consultant Radiologist, Nanavati Super Speciality Hospital, who will be moderating this particular session, and Mr. Anupam Agarwal, Director Consort, Overseas New Soft Medical System. I'll hand over the session to Ms. Verma here. Dr. Verma, please take on. Thank you.
Thank you, the entire organizing team, and thank you specifically to you, Pratibha, for taking all the efforts and for bringing this wonderful conference and definitely a fruitful panel discussion which you have arranged. So, myself, Dr. Mitusha Verma, and I'll be moderating the discussions for today. So without any further ado, I would like to start the panel discussion because all of us are waiting for our elite panel to showcase and to give us the clarity about the doubts we have. So I'm just starting my screen share. So I hope my screen is visible.
Yeah.
So the entire two-day summit has been organized in a manner that all important topics related to what radiology and radiologists are facing during these pandemic times are covered. So this particular panel discussion of around an hour will be about digital age adapting to the new normal. The panelists, as Pratibha already said, are Dr. Deepak Patkar sir, our President IRIA, Dr. Sikandar Sheikh, Dr. Jijo John sir, Dr. Geetanjali Nanda ma'am, and Mr. Anupam Agrawal. So all of them are experts in their particular fields. And let's see in this short time, but we'll try to sort out most of the doubts we have. So to begin with, I would like to start with Sikandar sir, because COVID times we all faced a lot of difficulties. We came up with a lot of new kind of solutions to our problems. But oncology is something, a branch which can never wait, because timely treatment is the crux in oncology practice. So Sikandar sir, I would like to know your experience and how do you think COVID has impacted the oncology imaging practice? Over to you, sir.
Thank you, Mathusha. First of all, Onco, as it is already mentioned here, it is very crucial and important for the timely treatment. That is very important concept. But since the COVID has started and then there was a lockdown, so majority of the Onco setup practice or the Onco imaging comes from the oncology department, and majority of the Onco departments, they are in the major cities or in the tier 2 or tier 3 cities or in a bigger hospitals only. The flow, most of them, they are coming either from the cities, and couple of them, they are from the villages and the rural areas. But here the major impact was because of COVID. First of all, people were apprehensive to come to the hospitals. That was the first impact which COVID had in general. And second, oncology, there was another added superstition or something which is a fact rather than calling as a superstition, because most of the onco patients, they are like their immune system is very low. So any sort of this involvement in the hospital, they are fearful that COVID will have an impact. And since the blend, like majority of them, they are coming from the rural areas, the major impact which had on the oncology was the transport, because they are from the rural areas, no transport is there, they cannot come to the cities or through the center where the oncology practice is being there or treatment is being offered to them. So that was one of the most crucial point which has a lot of impact. But still, like despite of this, there were instances people have to encourage, but still they were not coming. So unfortunately, we have seen the cases which were crucial in the timeline, like stage will become stage 2 if you are delayed for a month or a couple of weeks. So probably it has happened in a very rampant way. The staging of entire disease pathologies has been upgraded. So that is one of the biggest impact which had on our
Correct.
the oncology. That is a very worrisome, but unfortunately it is a fact, because we are also helpless. The government is also helpless, and the system of lockdown was also helpless in that. It was like a circle where one was leading to another and another. But still, like since we are coming back on the unlockdown process, probably now they are coming out and they are trying to get motivated to go to the cities and get treatment. But still there is apprehensive even today, because patient doesn't come alone, he has to come with the attender. So attenders coming, staying, hotels are not there, accommodation is not easily available, people are apprehensive for giving their accommodation. So these are all other social factors, and the important is the financial aspect also, because most of them, they have lost their job, they are not having good earnings. So probably that is also one of the way which has impacted a very different way. So it is like ultimately combination of social, logistic, financial, and the government decision factors. So definitely, I feel in one word, it is a negative impact.
Correct, sir, and we definitely agree. And you have kind of summarized all the various impacts the oncology faced. As we know that in oncology, the first step is most of the time taken by radiologists, because we are the people who diagnose it, stage it, and true, as sir said, all of us have experienced this, that patients approached at a later stage of the disease due to fear of COVID being going on and fear of coming to a hospital setup where already COVID patients are admitted. So, really, a negative impact. Now, with this, I would go ahead and would like to ask Geetanjali ma'am. Ma'am, if you could highlight and you could tell us about how do you feel, because impact we already faced since last few months, but would there be a long term impact of this COVID, ongoing COVID, the pandemic, on standalone centers, private setups, corporate setups, and public practice setups, ma'am?
Thank you, Dr. Midusha. We at Mahajan Imaging in New Delhi, we have 9 centers. 5 are standalone centers and 4 are in the hospital setup. So we have first-handedly seen the effect of COVID on both the standalone centers and the hospitals. As Dr. Sikandar just said, patients are wary of coming to the hospitals and they prefer coming to the standalone centers right now because of the COVID scare. So initially, we can understand during the lockdown, the work reduced drastically all across, and it was almost 80% less than what we used to do. But with opening up and with all the SOPs in place, people prefer coming to the standalone centers now. What impact it has made on our practices is that our staff has become more trained in following the SOPs. The policy of fast in and fast out is strictly followed by for the patients. There is least amount of waiting time. The patients can wait in their cars. They don't need to sit in the center. So things are more streamlined now. One thing that we used to do before was that patient used to come for the test and they used to come again for the reports, the films and the CDs at a later time. What we have started doing is that the films and the CDs are given to the patient at the time of the test only, so that the patient does not have to come back. The reports are sent on the mail. This is one process that is going to be followed for the long term. The patient does not need to come again for the reports now. One negative impact that has happened is the reduced patient connect. It is extremely sad that we have to talk to the patient on phone, like other teleconsultations happening. And especially I being the MRI consultant, any of us who undergoes an MRI in a claustrophobic environment for 30 minutes wants to come out and ask, kya nikla? What did it come out to be? And now the protocol is that you have to check the patient out, put him in this car, and the patient is still wondering what did come out of my MRI. and then you call on the phone and you tell the patient that, you came for a headache, but I'm sorry that you have a tumor. It is inhuman. This practice we cannot follow. I would like to go back to my patient and tell him on face what has happened. So this is one impact that is not a good impact, and we would not like it to be a long-term impact for our patients. Otherwise, our procedure has become more streamlined for us.
Yeah. Correct, ma'am. True. We also agree, and I think most of us know that a lot of things which may now can call unnecessary, which we were doing, calling patients back, as ma'am correctly said, for films and CDs, and they used to sit for some time for the reports. Next day also in the waiting area. So true, a lot of things we streamlined, and the actual procedure which was really important, now actually we are working with those kind of workflow procedures. So these were few positive impacts, but definitely a lot of negative impact features and factors are there, which we are going to sort out, I am sure, with the new normal coming in. So now I would like to go next with the next question to Dr. Deepak Patkar, sir. And sir, I think you will be the best person as President IRIA to talk about the diagnostic modalities being utilized by radiologists for COVID-19. So all of us know that CT scans have become like the master imaging investigation in these difficult times. So kindly guide us through what is CT and how it's helping out.
Sure. So a lot of people did a lot of things along with PCR. So when COVID started, there were about 7-8 labs across the country doing PCR testing. As we talk now, there are more than 80, and the tests conducted are about 10 to 12 lakhs a day. In the beginning, we had enough number of CT scanners, we had enough number of X-ray machines, but no PCR testing happening. In Mumbai, we had just Kasturba Hospital. Now we have 10 of them. The turnaround time of the test was long, minimum 24 hours, maximum 48 hours. And on Sunday, it would be 72 hours. So a lot of people initially started using X-ray as one medium of detecting COVID. A lot of AI softwares came in. Slowly, that passion died down. People realized that only in advanced cases of COVID pneumonia, you would pick it up on CT. Things quickly move on to HRCT without contrast. There were issues about patients being triaged into normal, suspect, and positive, because you had to wait till actually the result of RT-PCR came in. Then rapid came in, where with low sensitivity and specificity, we have some means of correlating it with CT. So currently, as we talk, CT is used, one, to maintain a census. Across India, even now, we will have thousands of CTs and few RT-PCR labs. X-ray chest and CT severity index and CORAD scores have become very, very popular amongst all the clinicians treating COVID. One, to detect and suspect. Two, to speculate and prognosticate the eventual outcome, and stratifying the patients depending on severity index. So we have CORADs and we have severity index. So putting these together, CT provides a tremendous roadmap, and quite accurate that too, to the clinicians treating the COVID cases. They now act looking at first CT as to how we need to treat, who will require remdesivir, who will require Fabiflu. Of course, these are all predictive things, but CT has become like a gold standard for treating and following up patients with COVID pneumonia. We know that it is more sensitive than CT, than RT-PCR, but false positives are also there. So we have to be a little more judicious. The other major advantage of CT scan is very short turnaround time. Like Gitanjali was saying, as soon as patient comes out, the clinician standing there on phone would like to know whether patient has COVID pneumonia or no, and if it is so, how much. So current recommendations from IRIA, ICRI, and from ACR is, in suspected case of severe acute respiratory illness, you should do CT scan, even if RT-PCR is available or not available. Molecular diagnostic test is readily available or not. In emergency situation, when patient requires intervention or emergency surgery like stroke, hematomas, heart attacks, CT scan is the way to go. Even if patient is COVID negative, if a surgeon is going to perform high aerosol generating procedure, you have to do a CT chest. For proven cases who are hospitalized, if there is unexplained deterioration, sudden deterioration in the clinical condition, when you are suspecting pulmonary embolism, secondary infection, ARDS, etc., you have to do a repeat CT scan. CT brain in suspected cases of acute necrotizing encephalopathy is also necessary. Also, we need to know that as for our own experience and also studies meta-analysis done abroad, sensitivity of CT is 90.4% compared to about 70% of RT-PCR. Till now at Nanavati Hospital, we have done almost 2,600 CT scans, and we can very well triage these patients based on whether they are COVID positive, suspects, or normal. So that is the role of CT scan today.
Thank you, sir. And definitely CT has come up a big way in helping triaging these patients and helping to categorize these patients into mild, moderate, and severe. Not only this, but we are also following up these patients of COVID because there is a large population of post-COVID sequelae patients now, which we are following up with these radiology tests. Thank you, sir, once again. Now, my next question is for Dr. John. Sir, we would like to know your experience as an interventional radiologist because now it's not only about diagnosis but also about treating these patients. And some of them are real emergencies where you cannot wait for those RT-PCR test results also to come up. So, over to you, sir. Yeah. Dr. Johnson, you can just unmute.
The COVID-19 pandemic it had a. Am I audible now?
Yes, sir. Yes, sir. Now you're audible.
Am I?
Yes, sir.
Yeah. The COVID-19 pandemic has had a profound impact on IR services. So mainly we divide the IR services into emergency and elective. So there's no doubt the electives have drastically come down to around 40 to 50%. And the emergency, we mainly divide it as non-COVID emergencies and COVID emergencies. Now, the non-COVID emergencies, because surgeries are now seldom done because the most of our anesthesia staff are transferred to the COVID wards as to take care of the patients over there and ventilatory support. So they are culling the anesthesialists. So we get a lot of procedures like acute cholecystitis, which has perforated, acute appendicitis, which is perforated because the surgery was not done on time. So a lot of procedures like image-guided drainages have increased. Then especially central line insertions on patients under image guidance, that also has increased. Then COVID emergencies like, as I said, stroke, pulmonary embolism, all these require venous thrombolysis. So such procedures have increased. But when you're looking at the big picture, I would definitely say that after the pandemic, around 40 to 50% of our work has come down. And probably it might pick.
Thank you, sir. So truly a mixed picture and a lot of new emergencies, the situation, as you have said, coming up because of delay in getting the elective procedures on time. So definitely all of us are facing this impact. And with this, I would like to ask our next panelist, Anupam Agrawal, sir. So kindly share your experience, the impact which you faced at your professional front with these ongoing pandemics, regular lockdowns, and now unlocking. Over to you, sir.
Yeah, good evening to everyone. What I have experienced and during the COVID time, most of the hospitals they were not taking cases than COVID, because first of all, patients were also scared to move into the CT room, and doctors were also doing the COVID cases only. The only good thing what I can say due to COVID, what happened, you know, the cleanliness which was not there earlier into the CT room and the equipment maintenance, probably that started happened, and because of that, probably machine will run for more hours than before, and it will help for better workflow. This is what I can feel now. And earlier, the technicians were not, taking care of standard protocols, but they are more cautious, and things are started happening, in a more
Correct, sir.
international way.
Correct, sir. So,
This is
as
what I
all
can
of
say.
us can come to a conclusion with these 4 and 5 initial questions, that all the panelists agree that processes have become more streamlined, and we are doing a kind of work in more standardized fashion, not only at our own institute level, but also it's like a world over standardization of protocols, though the change was really dynamic. So, with this, we come to something which is the constant. As we know, the only constant is change. So, change is inevitable. And this time, the change was a little sudden, little quick. We have to get adapted to all this. So, I would like to ask Patkar, sir. Sir, could you stress on the need of the radical changes in protocol right from hospital admissions? Because we know you are also the director of medical services at the Tertiary Care Center, Nanavati Hospital. Uh, Also, as head department of imaging, the changes you have done in diagnostic methods, disinfections, and with these changing regulatory laws. Over to you, sir.
So in the month of March, mid-March, it was war-like situation. We used to hear news that China made hospital 1,000-bedded hospital in 10 days, and we used to laugh our eyes to see, understand how it could happen. It was just not possible to make hospital 1,000-bedded hospital in 10 days. But actually, Mumbai Municipal Corporation made these hospitals, 3,000-bedded hospitals in 10 days. So things like this really force us to increase our speed, change quickly, understand, rechange things. At our hospital, which is a 450-bedded hospital, which is spread across 3 buildings and 6 acres, we had relatively less problems. People who were in one tower had major problem as to how to triage or separate out patients into 3 categories: negative, suspect, and positive. And it's a humongous task getting these patients in without relative. So we used to send ambulance to their home, get them in, no relative coming in, payments made online, or somebody coming into taxi and getting out at the gate and coming in. We started screening and triaging at our entry gate. So our hospital became like a fort. It was scary to enter for us also who were working there for decades together. At the entry gate, we created 2 different entry gates. Exit gate was closed. Entry was made into entry and exit for non-COVID patients, and exit was made into entry and exit for COVID patients. At the entry for COVID patients or suspect patients, there was screening triaging created. I don't know whether Mitusha is sharing the slides. I can see them. Social
Okay.
distance, yeah, if it is possible. Otherwise, it's fine. Social distancing was created in OPD. So we have OPD footfall of about 900 to 1,000 patients per day, which is of course now down. Now handling 1,000 patients across 12 hours can be humongous task. And our hospital is spread out horizontally than vertically. So creating those footprints where patients could stand or making circles was another thing that we did. Other thing that we had to do was creating green corridor for non-COVID patients and brown corridor for COVID and COVID suspect patients. Again, separating out suspect patients from positive patients. So it was a very critical and humongous task. It was not only about creating it, it was also about creating perception of safety, which was even more challenging. As far as the radiology department is concerned, we divided our portable machines, 6 ultrasounds and 12 portable machines equally, half for non-COVID patients and half for suspect and COVID patients. Again, corridors were created completely separately. We, in our own department, we created glass walls over a period of 10-15 days so that our staff remains safe. Keeping staff safe was a human task again. Out of 2,500 personnel that we have in our hospital, working with patients or working away from patients, backdoor, almost 500 got infected in first 3 months. So again, creating perception and actually protecting them was a humongous task. Out of 2,500, 1,800 patients, 1,800 personnel was given HCQ because we thought that would be useful at that time. We gave multivitamins to everybody. We created facilities within hospitals for residents and level 3, level 4 staff and nurses to stay in the campus. Tatas and Oberas helped us in creating that facility within a matter of about 20 days. We created a separate lift for our COVID positive and COVID negative chronic renal failure patients. Again, creating a healthy situation, cleaning the walls, cleaning the floors, cleaning the horizontal surfaces, cleaning the holders was a humongous task. Teaching our level 3 and level 4 staff as to how to get themselves trained, cleaning everything every hour. Our consumption of disinfectant went up by 140 times, not 140%. In the department, again, we had to defer the use of pressure injectors for a while. Additional PPEs were provided for anesthetists as well as level 3 and level 4 staff. We have a very, very strong code white protocol for stroke patients, which had to be changed from MRI to CT scan because we had to do chest CT parallelly along with CT brain. So a lot of activities had to be completely remodeled based on what needs to be done. We have one CT and one MRI. So triaging these patients was not possible. We did not have separate CT. We thought of having a portable CT, but it was not happening because unavailability of transport. So we created a separate corridor, and we even today do CT scans for COVID positive patients between 8 in the night to 2 a.m. in the night. So creating the separate corridor, training the staff was again a humongous task which we had to, over a period of time, settle down. Thank you, Pritisha.
Thank you, sir. So a lot of reorganization, and as sir said, a lot of protocol changes, like even the stroke protocol had to change from MRI to CT. And we had to take care of our staff members as well because they were the most important part of the entire unit with patients and definitely our machines. So my next question is for Dr. Sikandar sir. And sir, the question for you is like, what are the economic implications of regulatory restrictions which were imposed by the government, like capping of prices and implication of strict social distancing norms and cleanliness and sanitization norms on small centers? Over to you, sir.
Yeah, this is very important aspect actually, because a lot of small centers and the diagnostic centers and small hospitals, they are the major ones which have faced the brunt because of the, first of all, less number of cases, less number of patients. It was very difficult for them to sustain. Secondly, the government is already having a cap, so there is not much of a earning revenue as far as from the imaging side or entire hospital side is concerned, or diagnostic centers. Then third, to add that, there are a lot of social distancing aspects, like you should have sanitization and other aspects like PPE kits for the staff and other things. So it has added further to their expenses. So obviously it is a not a healthy aspect for them, and that was one of the reason majority of the staffs were like they were either removed or they were reshuffled. So it was like all the way from the hospital side, staff side, as well as patient side, economic side, it is again in a negative way. So it is very difficult. Even by government has put a capping on their way, but on other side also there are corporates and all that which are charging heftily. But this doesn't happen in the smaller diagnostic centers or hospitals. So obviously the generating revenue during this COVID times is very difficult for them, and it is really challenging. Again, the even the salary aspect is also impacted on that, because most of the centers, they were either giving whatever percentage ranging from 25%, 50%, or 70, 80% in different ways. Even the places where I go, I have faced the same thing actually. So it's not like that the economy, the system, everything has been deranged because of this COVID. And ultimately, to come out of this is not easy, especially for the smaller centers and diagnostic centers. So it will take a long time actually to come back to normal. Even though the unlockdown is there are a lot of patients which are coming back, but still 80-90% of the practice is become normal, but still people are apprehensive. Still electively they will come for imaging actually, unless and until it is warranted. And same in couple of centers, they have routine protocols like master health checkups or something like executive health checkups, where people are not so much keen to get it done unless and until they are really wanted to get it done. So it is obviously ultimately a negative impact in every aspect.
Correct.
So for that, I think in future, we again couple of months, it is going to be the same scenario.
Correct, sir. So a lot of new things from government side also coming up, and we are like kind of in a fashion, even if we are not comfortable sometimes, but we have to follow them, and it might be really difficult for small centers to cope up. So with this, we move ahead to the next questions, and that is for Gitanjali ma'am. If you could just tell us, ma'am, how you dealt with the situation in terms of staff and human resource management and redistribution, as well as reorganizing everything in terms of the staff members, paramedics, and doctors. Over to you, ma'am.
Thank you, Dr. Mitusha. As Dr. Patkar rightly said right now that, in mid-March, the world came to a standstill and everybody was inside their houses. So the only good thing that happened in Delhi was that for the first time we could see the clear blue skies, which usually doesn't happen. We are stuck in pollution, stuck environment. But initially all the transport was stopped. There was no way for the staff to come in. So as sir said that we had to send our own ambulances to pick up the staff, and we had to manage our centers with the skeletal staff, the least possible numbers. And especially in the front office, we would not like people sitting together. So we divided the staff into shifts, and we used to give them weekly offs. And with the numbers coming in, as I said, that people preferred coming to the standalone centers. So eventually now we have almost picked up our pre-COVID work. So we had to bring in people, but all the non-essential staff which is not required in the day-to-day running of the place, like the HR, the admin, and the account department, they still work from home for us. None of the people who have to come into the center just for the crowding are allowed. Even in our COVID lab that we have set up for the RT-PCRs, all the registration process, all the data entry and the report generating staff and the call center staff, they are still working from home. So only those people who are required to run the center, especially
Yeah, I think ma'am.
It is got stuck. We can't hear her.
Yeah, sir. So we'll just try and reconnect with ma'am, and meanwhile we can go ahead with the next question, and we'll come back to this with Gitanjali ma'am. So, Dr. John, we would like to know from you, sir, like what do you say that we are, when we say that we are at crossroads as far as healthcare is concerned, because a lot of watershed gray zones have come up where we are a little confused where to go and what decisions to be taken. And what will be the aftermath of this crisis? Like, how will we kind of adapt some kind of you feel that these will be the main key game changer points at this particular juncture with this pandemic?
Thank you, ma'am. Definitely, we are at a crossroad. Now, the healthcare industry, it has not changed such drastically since the past pandemic. Now, modern medicine, the emphasis till now was on the clinician seeing the patient and then treating him. But this has now changed to telemedicine. So where the patient doesn't have to be physically present near the doctor, and he can give his orders and see the patient through telemedicine. So that's a big change. Then I feel there's a big role for personal monitoring devices, which will be really handy. Like already a lot of watches have come which are linked to your mobile, and it is also linked to a central server, which will tell you about any abnormalities in your SpO2 or your pulse rate, even the ECG. So there is a lot of scope for personal monitoring devices, and you don't have to physically go meet a doctor. Telemedicine, as I said, there is tele-OPD, tele-ICU management, and probably insurance will become a part of life where everybody will get a health insurance for sure because of the cost of treatment. And coming to diagnostic services, all the hospitals will require a very good HIS, and HIS is a hospital information system, and which is integrated to a RIS and a PACS system, so that the radiologists can report all these, can report sitting at home probably, and things like ultrasound. There are centers which are now employing technicians to do the ultrasound, and then they are uploading the images so that a radiologist can interpret it. So even that is this is all like post-COVID era. Even the West was doing it earlier too, but in India probably it has started a new revolution. And definitely there is a lot of scope for AI. Now it is in a nascent phase, but I'm pretty sure that in the near future you'll have a pretty good AI algorithm which can detect much more given database, and probably it will also help us to like a radiologist. It won't replace a radiologist, but definitely it will augment the radiologist. So these I feel are the changes which will come in the near future.
Sure. So, with this, the way sir has correctly told us about the aftermath and given us some ideas into it, I would like to ask Anupam Agrawal sir, like, what do you think, sir, the future with semi-automated and automated medical system and devices, as we are kind of trying to safeguard human resources during this pandemic? We are trying to work from home and kind of moving towards automation. So I would like to know from you, sir, something regarding the future of automation.
See, I believe in all the hospitals, not only COVID, in future, we can expect any kind of diseases. It is important to have the kiosk where patient can enter in the ID and get the printout of the films if need be. Otherwise, as everyone is concerned about the teleradiology, that would be the best solution.
Okay.
So I think to move further, it is important to modernize our system, HIS, specs, teleradiology, and these are the ways how we can move further and optimize.
Correct, sir.
That is what I can say.
Absolutely. So we definitely are looking towards an augmented kind of medical and healthcare system where there are machines and there are automated devices to be more accurate and to help us with our routine practices, where the human mind can be utilized for better jobs like logical thinking and coming up with the management options for the patients. So with this, I would like to move to the next question. And for this, again, I would request Dr. Patkar, sir. So please let us know, like, what can hospitals like do better the next time in terms of managing a public health crisis of this magnitude. So as we all know that when it started, there were so many kind of talks about people talk who have predicted that something of this magnitude can come up in the future and that world may be at a standstill. But now we faced it. So kindly suggest, how can we better be prepared next time?
So basically, something like this happens, we start hunting for solutions. We had never imagined that an infective disorder like this could shut down the world. Everybody was working at molecular imaging, molecular treatment, cancers, degenerative disorders, disorders of aging, because our age factor has gone up quite a bit over last 3 or 4 decades. People live for 85, 90 years very easily. Average age in Japan is 90 plus. Average age in India is 75. So people are looking at geriatric medicine, cancer, heart attack, etc. With best of the antibiotics now available, people thought that infectious disease is the least important thing. So there was no preparation for this at all. Now that we know, we should be improving and increasing public health infrastructure. That is the need of the hour. What all of us know is all these tertiary care and quaternary care super specialty hospitals are made. They are made not for these kind of situations. They are made more for high-end treatment like liver transplant, lung transplant, heart transplant. Uh, they are made basically for taking care of cancers, orthopedic problems, etc. So we need to have a good public-private partnership. There has to be better spending, not only by government but also by powerhouses in India on healthcare. We have to have better diagnostic services, and like Mr. Anupam Agrawal said, we have to have complete focus on technology promotion. We have to go wireless, we have to go SIMless, we have to go paperless. That's the way forward. Beyond that, environmental safety and cleanliness is also equally important. We, while social stigma, are not a very, very clean and safe country. So a lot of focus needs to be given on keeping ourselves clean and healthy. Securing liquidity is another thing that was taught to us. We presume that we're going to earn what we earn for next 30, 40 years. Sudden dip in income is not many people in our population were ready for. We have to have specialties dedicated to ailment care. We have to have wellness clinics. There has to be need for dedicated public health emergency laws and regulations. We kept changing laws as and how we learned. Other important thing is healthcare expenditure in our country is very, very abysmal. We spend 1.29% of our GDP for health. Countries like Japan and Germany spend close to 10%, 9.2 and 9.5% respectively. BRICS countries, which are similar to us, spend anything between 4 to 8%. US spends 14.3%. So we are nowhere there. And unless we do that, the number of beds per patient, which is at 8.5 compared to 100 at Japan, will not change. So lot of need to improve the infrastructure. We need to standardize the healthcare system across all the states. There's a lot of discrepancy between what is available in metros and what is available in smaller towns or villages. Other big thing that we've learned over the last 6 months is the trust gap that has been created between general population and doctors. Because as doctors, we're not very communicative. We don't know how to put things across because communication is not taught to us. So doing good things is not good enough. Making them aware that they're doing good things is important. And we have to promote Make in India. Nothing of this is available. We have to import everything. That has to stop very, very quickly. And for that, conducive environment for investment is important. Over to you.
Thank you, sir. And as you rightly said, we have to be kind of go towards Make in India self-dependence, as our honorable Prime Minister always tell us to be Atmanirbhar Bharat. So initiatives like Ayushman Bharat and a lot of new things coming from the government side and this public-private partnership, as you spoke about, looks to be the solution in long terms. With this, let's go ahead to the next question. And this is a little specific for Sikandar, sir. Sir, like in nuclear medicine department, we know as like PET scans, for example, patient have to come and we have to inject a particular contrast agent or radioactive agent like FDG, and they have to wait for a longer time in the department. They usually are frail onco kind of patients who require some kind of assistance with them. So how did you deal with this difficult situation? Because CTs, they just are like minutes of scan and done. But how did you deal with this crisis specifically in terms of nuclear medicine department? Over to you, sir.
Yeah, thank you, Mitusha. Yeah, this is very important question because initially when the lockdown started, we were doing very less cases because the patients were not coming and they're not referred. Same question, same answer. They were apprehensive. They don't want to spend the time. And the thing was like since PET nuclear department, it is a radio tracer. You have to inject. Probably one PET scan usually takes around 3 hours. They have to spend. They have to come. They have to get injected. Then they have to, if needed, you have to do the delayed scans and all that. Probably estimated time is roughly 2 to 3 hours. So handling this was become very difficult actually. And since as far as our chain group of hospital is concerned, we have two PET cities. So probably we manage in such a way that 3 days we are doing in one center, one of my branch, and 3 days we are doing in another branch, because we are pulling the patients in. At first of all, patients were less, and pulling the patients to minimize the amount of the fear of having a COVID. And we were scheduling. Important thing is we were scheduling appointment as early as possible in the morning. We used to start routinely by 8:30. Probably we are starting around 7 o'clock, and 6:30 we used to call them, inject them 9 o'clock, and probably we will try to finish all cases by probably before lunch. That was a thing which we have to do, because they have apprehension that even our building was allotted to the COVID ward completely. Still, there was a big apprehension. So separate lift was created for we have 2 3 lifts, so only one for the nuclear patients, so that they should not have any fear of having that getting a COVID or something like that. So their movement was separate from our floor, lift was separate, and it was like as fast as possible we used to do the things, and unwarranted delay was being minimalized as much as possible. And the reports, as far as reports were concerned, dispatching, we used to do take their online, and all our the reports are available online. And the digital films and all that, if whoever consultant they want, they can see it. And physically, if they want to collect, they can come and collect the reports. But most important, the time factor was changed and the timing was changed for the convenience of the patient. But still, we were not getting enough number of cases. Now we have come to a stage where it is like roughly 70-80% of the total PET cases which we are doing pre-COVID times. So this was an important thing which was happening. Even same with the nuclear other procedures also, nuclear department, same was early appointments and make them early, release them as early as possible.
Correct, sir. So definitely a lot of changes in each and every, though it looks like little kind of unified that yeah, radiology practice, radiology scans, but each and every department is different. So nuclear medicine department has its own challenges, as sir already spoke about. Ultrasonography has its own challenge because the doctor has to be in close contact with the patient. You can't handle patients remotely. So everywhere, even MRI scanners, the coils have to be placed right on top of the face of the patient. And if it's a COVID patient, you have to be really careful of cleaning the brain coils and other coils very diligently for taking the next patient. So we faced all these challenges, and yes, we got almost well with whatever problems we were posed with till now. And with this discussion, we'll definitely come up with more and new of these solutions. Now, I would like to ask Geetanjali ma'am. As we all know, Mahajan Imaging is one of the pioneer centers in AI, with Dr. Harsh Mahajan sir taking the lead. So, ma'am, it's important for us to know your opinion about how has AI and deep learning platforms helped radiology services, and what is your vision for AI-enabled radiology in future? Over to you, ma'am.
Thank you, Mitusha. Yes, we at Mahajan Imaging have a whole R&D division called as CARING, which is a Center for Advanced Imaging Research. And I'll start with just a little perspective that in 2017, National Institute of Health in US released around 1 lakh X-ray images for the researchers and academicians to come up with something in which they can a way to teach the computers to extract data and information out of those images. Within 2 months, in November 2017, the researchers from Stanford, they published a paper that the AI algorithm could identify the pneumonia on the X-ray better than the radiologist. Since then, it has been a Pandora's box. Like there are more than 100 companies creating AI devices for the medical facility. There have been more than around 50 FDA-approved AI algorithms, including the insulin glucose monitors, chest X-ray readers, and they have also been deployed in certain places like in immigration departments in Dubai and Canada. They have automated chest X-ray readers, which separates the normals from the abnormals. So definitely a lot of AI algorithms have come into practice. And we at Mahajan Imaging, we have developed an integrated platform in which our workflow can be integrated with these AI algorithms. Like supposedly in spine, there is automated measurement of the canal diameters. In chest X-ray, we can identify almost all the labels like pneumonia, consolidation, and mass. So as my workflow comes to the monitor, I also get a second report from the AI. What happens is that it is like having a constant second opinion with you. So AI gives you help. It helps you in speeding up your work. It helps you work more efficiently. It can also prioritize my work in the form that I can do my abnormal cases first and go on to the normal cases later on in the day. It helps me to identify the important cases first, like the way sir was saying that the CT stroke protocol has changed. So in NHS, they have this prerogative that, within 20 minutes, the CT scan has to be reported and the information about an intracranial hemorrhage has to be given to the clinician. It is humanly a little difficult, but with the algorithm in place, the identification of intracranial hemorrhage is very specific with these AI algorithms, and all these procedures are more evolved with the technical aspect. So in this manner, what I feel is that AI algorithms are already there, but again, everything has a two sides of the coin. This right now, what we are sitting in is like an AI bubble. In 2018 and 19, everybody was more hell-bent on seeing whether these things work and to develop newer technologies. Now we are at a place about how to incorporate these technologies in our day-to-day work life. So if I, as a radiologist, am using the technology of AI, I would prefer it to become my second assistant. For the younger radiologists who are freshly out of their PGs, it reduces their learning curve, gives them more confidence, and helps them to fine tune their quality. And also in the national programs like national tuberculosis programs and occupational health disease programs, where there is a regular screening chest X-rays for the workers, these algorithms can be deployed at a remote center where the radiologists are not available, at least to differentiate between the normal and the abnormal X-rays, so that these workers can be identified at an earlier stage and they can be segregated and all the health hazards can be identified. It also helps in the statistical analysis of the data. So all these things become very easy with the algorithms. But ultimately, the human touch is always going to be there. It is always a person who's going to tell the patient what has happened to him, and it is always a human who's going to take the medical legal implication of it. So this is how I see that AI is working right now, and AI is going to help us in future also. Thank you, Mitusha.
Thank you, ma'am. You actually wonderfully summarized everything about AI in a very short time. So definitely, we're looking forward to a lot of new solutions and quick solutions to our day-to-day problems with AI. And but human touch will every time be important. And doctor with AI is what the future is all about. So, nextly, let's move ahead, and I would like to ask Dr. John. So, is there a change in the distribution of patient load which you saw during this time of COVID era in between the vascular and non-vascular emergencies, like what we used to see as emergency and intervention in pre-COVID times versus now versus what you see in future? Over to you, sir.
Thank Definitely, there has been a shift. We are getting more of, pre-COVID times, the vascular emergencies were more in terms like post-party bleed. We used to get traumatic hepatic artery. But post-COVID, we are seeing more of stroke, pulmonary embolism. So definitely, there has been a change in the emergencies in the COVID, and it's like a dynamic shift, and we are hoping to overcome soon. So most of the emergencies, there's no we don't do an active intervention. And we usually put the patient on thrombolysis or some similar non-invasive. So definitely, post-COVID emergencies are okay. And as I said earlier, we are getting emergencies because the patients have not been operated on time. We getting operations, we cholecystitis, which are operated. That I feel will come down because more and more hospitals and will treat on time.
Thank you, sir, for that insight. And again, as you can understand, the panel completely covers the spectrum of the radiology practice with Dr. Patkar, sir, looking after as the head of the department and also as the director of medical services. Then Gitanjali ma'am, who have been closely working with AI solutions, and Sikandar sir with nuclear imaging, and at the same time, John sir coming up with all the intervention related issue. Everybody came up with their kind of challenges they faced during these difficult times, and we definitely got a great insight into what the future is going to be about and about the preparedness about getting into these challenges and getting out of these. So I think we have covered almost all the important questions, but just before we end, I would like to ask a few last ones. So this one is for you, Patka sir. Like, how has teleradiology helped us? Because everybody of us know that we have got a lot of flexible solutions these days. So your experience with teleradiology and its solutions, sir.
So I'll be very quick. I know we're running out of time, but it is always said that newer problems need newer solutions. Innovations are the way to go ahead, and we've seen a lot of innovations in the last 6 months, which would have happened over 6 years. Vaccine is one example. So digital solution for contact tracing, mass screening, mass sanitization did happen. Teleradiology, telemedicine was always there. We were underutilizing it. With this situation coming in, we will probably use it much more often because it's quite user friendly. It has remote access. You can do it on your cell phone. If you have a good cell phone, you can do it on your iPad. Timely expertise can be provided where there is no possibility of a specialist radiologist being available. It has outreach across the world. It ensures safety for all of us. You don't have to be really COVID warriors in that sense. It's a key enabler that we have learned in this battle against coronavirus. Emergencies can be reported online. You can avoid risk of exposure to the worker. It increases reach of quality healthcare across the globe. We know there's severe shortage of radiologists across the world. India is no different. And if all of us seniors can put right perspective and right protocols in place, we can reach across all villages in India. Thank you.
Thank you, sir. Now just to end this panel discussion
You
with
have to start your camera. Nitisha, you have to start your camera.
yeah, sir, I'll just start that. So, but I would like to ask Sikandar sir that, sir, all of you basically, Sikandar sir, starting with you, please tell few positive impacts which you think will come out of this pandemic experience. Just positive things we are going to talk about, and then we'll conclude.
Yeah. To the short, actually, the most and biggest positive aspect is like we are going digital. We are having very less contact. Actually, we can, as teleradiology, we can report from home or wherever it is. Then we are having all digital conferences, CMEs, and what today we are doing is also one of the example of that. And with this, most of the important thing is again everything is digital. Even transaction, payment, consultations, reporting, our entire medical system has become more of like virtual, and it is very easy. Actually, I think it is user friendly. Unwarranted things are being prevented, and definitely it is a positive impact.
Thank you, sir. Gitanjali ma'am, same question for you. Something positive you think will come out of this crisis?
One positive thing that I can see right now is that the world has become a very small place. Everybody can be together. So we are able to share the information faster. We are able to understand things faster. Whatever innovations are happening across the world are coming to every one of us. It is not restricted to just the West. And we are able to accept those practices much easier now. The way online schooling all of a sudden become a norm, the teleradiology thing has also become a norm. So it's easier to accept the digital solutions for us, and human mind has changed slightly. So this definitely is a positive outcome of the pandemic.
Definitely, ma'am. Over to you, John sir. Dr. John sir, please, what do you think the positive impact coming out of these difficult times?
Every failure is a stepping stone, is what I believe. And COVID-19 was unexpected. It has led to a lot of change, and by change, metamorphosis. So the last pandemic which we had was, I think, HIV or AIDS. And now when we think about that, the amount of research, the new drugs which are available for treating AIDS is like enormous. And at that time, everybody was disheartened, saying that probably 2 to 3% of the world population will be affected by AIDS, and they'll all succumb to the disease. But now we are seeing very less mortality. So similarly for COVID too, I'm pretty sure we'll get a very positive thing. A lot of research work going on for new drugs, and by the end of probably by the middle of next year, I think we'll have a definite cure, and we'll overcome it. That's my.
Sure, sir. And over to you, Anupam sir. What do you think? What positive things will come out of all these difficult times?
I can say only one thing, as Dr. Patkar mentioned, that facilities were available earlier also, like teleradiology, HIS, but those were underutilized. So probably due to the COVID, people have understood that what is the use of these technologies and how they can improvise and how they can optimize to use them in the times to come. And I think they have also understood the importance of the latest technology, as Dr. Gitanjali mentioned right now, the importance of AI. All the companies are working into it. And my request to all the radiologists is to please ignore the obsolete technologies, what people are giving to the radiologist. You deserve the best and the latest, which can improve your workflow and also improve the patient care by reducing the radiation dose. So probably it is very, very important. All the mentors are sitting here and they understand the importance of radiation, and probably this message will go to all who are not there at the screen, and they will help country to serve better. That is what I can say.
True, sir. So I would like to end up by saying that a very correct meme came up this Teachers' Day, and they gave the Best Teachers Award to the year 2020. So all of us learned a lot of new things. We understood the value of the facilities which were already there, and we came up with newer solutions as well. So I think with the entire panel today, we got insight into the depth of the topic, and all these experts took out time, and we are really thankful to their time, contribution, and efforts. Once again, thankful to the entire organizing team from ELET. And with these words, I would like to switch over the mic to you now, Pratibha. Over to you.
Thanks a lot. It was a very well-rounded session. It was like wholesome. I don't want to stop it, but we have time constraints. It was really good. It was a lot of deep insights. So thanks a lot for each panelist for giving a kind of valuable insights to it. And I would like to thank Mitusha for moderating it so well and ending with a positive question in particular. So we'll quickly give the speaker certificates right now. Thanks for joining in for each panelist and participating in this session. My screen in the back end, can you please? Thanks a lot, Dr. Deepak Patkar, for joining again, sir. We have been very sweet. You had, participating in various sessions here. Thanks a lot. Dr. Sikandar Sheikh, thanks a lot.
Thank you.
Thanks a lot. Thanks a lot for participating in the session.
Thank you, ma'am.
Thanks a lot, Dr. Jijo Joan, Consultant Interventional Radiology from Amala Institute of Medical Science. Thanks a lot, sir, for joining. Dr. Geetanjali Nanda, Consultant Radiologist from Mahajan Imaging. Thanks a lot, ma'am, for joining.
Thank you, Pratibha.
Yeah, thanks. And Dr. Mitusha Verma, for moderating it so well and taking the flow of discussion. It was really nice. Thanks, Dr. Mitusha.
Thank you, Pratibha.
And Mr. Anupam Agarwal sharing his views on the panel. Thanks a lot.
Thank you,
Mr.
Pratibha.
Agarwal.
Thanks.
Thank you so much once again.
Thanks to everyone.
Thank you.
Thank you to all the panelists. Have a good evening.
Thank you.
Thank you all.
Thank you, sir. Thank you.
Thank you.